Okay, I think we can get started. So thanks to all of you for joining us this morning for another edition of Discussions in Diagnosis. I'm Goutham. I am the principal investigator for the UH Advanced Center, which stands for Advancing Diagnosis through Validated Analytics and Novel Collaborations for Excellence. And we have a very special guest, as always, Dr. Ramin Khorasani. He's the Philip H. Cook Professor of Radiology at Harvard Medical School, Vice Chair for Radiology Quality at Mass General and Brigham and Women's. Um, he also is the founder of the Center for Evidence-Based Imaging, which is a multidisciplinary translational research center, which I hope we will get a chance to talk a little bit about today. Most importantly for me, he's a fellow Canadian, a graduate of McGill Medical School, a few years ahead of me. I think he was probably finishing residency when I was just getting started. So thank you for joining us, Ramin, this morning.
It's a
Uh,
big pleasure for me to be here. Thanks for the invitation.
Thank you. So, I think this is kind of timely because I just yesterday was looking at a radiology report from a patient of mine who went to the ER with abdominal pain, and somehow they did a CT scan of chest, and she has a thyroid nodule. And at the very bottom of the report, it says recommend fine needle aspiration because of its size. And I would have missed it if it wasn't for this today's session, as I better look down at the very bottom to see what I'm supposed to do. Hopefully somebody else would have picked it up. So I guess I want to start with, tell us a little bit about the inspiration for the DECODE grant that you have from AHRQ, and what problems are you trying to solve?
Well, first, I think I appreciate the subtlety and the importance of the case you just used as an illustration, and uh, that's a that's something that happens multiple times a day in all of our organizations, and I think it's fairly clear that um, in our work around diagnostic errors that have become so prominently recognized as a um, as a major contributing factor to patient harm in the United States, that has translated to us in a very practical way to look at these radiology events. Going back to 2017, 2018, we were looking at quality improvement efforts to identify areas where there is potentially unwarranted variation. And we identified in radiology that even in highly subspecialized areas in radiology where everybody's working in a very close quarters together, there's 6 or 7 fold variation in how people make recommendations and the variations in language they use to make those recommendations. We also had, and I'll talk about that in a second, we also had very unfortunate safety events around the same time, early 2018, where despite everybody's incredibly hard work and best efforts, cases like you're talking about fell through the cracks. The example that I recall really motivated and animated a lot of people was a patient who came to the ER with a headache, acute headache, but had a cough. The acute headache CT showed a little bit of hemorrhage around an aneurysm, and this patient had a 4 centimeter lung mass on a chest X-ray. Both were communicated in a closed loop communication tool with the ED doc. The patient got admitted, was transferred to our main hospital, had neurosurgery done and discharged, cured of the immediate risk to his life. But somehow that 4 centimeter lung mass on the chest X-ray and the bottom of the report in the discharge summary from the ED said, get a chest CT. That chest CT didn't happen. And the patient died 18 months later of metastatic lung cancer. And when we were reviewing that as a safety event, and it went to our quality committee of board of trustees, there are several things that became really apparent after we had discussed it with the patient's family. One was that follow-up recommendation that wasn't immediately acute got lost in all of the medical records activities that the patient had because there was no flag that something needed to happen later. And dishearteningly, the family, very well educated family, that we were meeting with, and these are highly trained, highly educated people, said if somebody had told us that we needed a chest CT, we would have gotten it. We're at the hospital every
Yeah.
couple of months for a visit or another. So the patient wasn't aware. We didn't have a good communication on how the handoffs for that follow-up had occurred. The chest CT would have captured the patient's malignancy a lot earlier. And I think what happened through these events, the work, the sort of the broad academic work around variation and these acute safety events that the leadership in the organization decided that they wanted to make this a priority. And this, this is a very hot topic, obviously, around diagnostic errors. So missed and delayed diagnosis and failure to engage the patient to make sure that you have a timely connection with the patient. So there are multiple pieces to the puzzle, but that resulted in a lot of work on our side to understand what the parameters and what the issues were. And I think you obviously identified a very clear message at the bottom of the report saying, ask needle aspiration. But our colleagues who are working every day in medicine, and I think you will recognize some of these words that radiologists use in their language, there could be something like consider MRI. Well, what does that actually mean? And how do you build a system of care around that? Because we know humans will fail to execute consistently on that. And if I read one of your patient's MRIs and I said, consider MRI, and there's no MRI done, is it because you considered it and you decided you didn't need it? Or is
Right.
it because you considered it, you wanted it, but you just weren't able to get it entered, executed? So we realized very quickly that to create a system of care around this topic, we needed to create new tools and new workflows and look at some behavioral changes and
Let's
practice
talk about
patterns.
those. Yeah, let's talk about some of your successes, perhaps in preventing the first example that you gave us with the lung lesion. What kinds of things have you done?
Um, I think the most important element of that is training our radiologist and working with our radiologist to, if they are making a recommendation in their reports, that it is actionable, that it includes a modality, a body part, a rationale, and a time frame. What you need as an order in the electronic health record. And what we've done is we created a closed loop uh, process by which when a radiologist is making those recommendations, they're really required to put all of those in. And what we're doing, all those data elements in, and what we're doing is we're asking our referring providers to react to each of those recommendations to document whether they agree or disagree. And if they agree that collaborative care plan saying this, we need this chest CT and follow up to happen, we follow that up in the electronic health record using a data analytics tool to track whether those cases happened. And any cases that haven't happened, we have a very robust safety net team to capture anything that has fallen through the cracks. So, the challenge is how do you scale that? And I think that's the essential workflow that we have put on the ground. That's saying if you're a radiologist, don't use ambiguous language. Make sure your recommendations are actionable. Using a closed loop communication tool to ensure actionable recommendations are captured, and then asking our referring colleagues to opine explicitly on those actionable recommendations to agree or disagree.
So who puts the radiologist basically puts the order in, and as a physician outside of radiology, I approve of it, or how's
Yeah,
that?
I think so. There are a couple of ways that it's possible. One is in our electronic health records in Epic, and we're on Epic. When a radiologist makes this explicit recommendation, there is the ability to map it to an orderable in Epic. And when that shows up as a BPA, as a best practice advisory, when you are interacting with the result, you can actually agree or disagree. You can agree by clicking a button and creating the order,
Mhm.
You can actually, in our BPA, say, I want a care coordination team to transcribe this order for me. Or you can say, I disagree with this recommendation, and it will go silent. So the clinical necessity is determined by two physicians agreeing on what the patient's needs, and really at the discretion of the responsible clinician, because radiologists may not know all
Right.
the details about the patient's presentation, but putting that in front of you, in addition, if you like, as an actionable object, in addition to reading your text report,
Mhm.
allows us to capture that action in a very explicit fashion through our safety net programs. And I'll
That's
try to
really
keep my
extraordinary.
question brief.
So I'm reading the radiology report. I have a result in my Epic inbox. And then as part of the report, something else flashes up on my screen and say, here's the actionable order that we recommend. That's that's
That's
that's
right.
that's fantastic. So you mentioned this, and this is our third major question about scaling. What are some of the challenges for scaling this up, perhaps to other systems?
I think the most relevant thing for us is one is the tools, the closed loop communication tool, to ensure that you have a discrete recommendation and a discrete reaction by so that's easy to understand from an informatics perspective. But the bigger changes are ensuring that radiologists enter these recommendations in an actionable fashion, because if radiologists don't put that in an actionable way in our closed loop communication tool, there is no trigger to start the cycle. The second is, I guess, the third piece is to ensure that you do have a safety net set of resources, a team to capture the ones that could fall through the cracks, because if you don't, you lose the trust of our physicians that this system actually works.
Mhm.
Because we know some of these will fall through the cracks. So you have to resource not just the build of the IT framework for the workflow, but you have to have the safety net resources to make sure you actually have a system of care. And then that allows you to then uh, continually improve the interactions between radiologists with the system to initiate the cycle of closed loop communication. Does that, I
Yeah,
hope
yeah,
that
yeah, absolutely.
that explains.
So I think our next question is something that Dr. Koopman Gonzalez has raised here, and I was wondering about that as well. What is the there's probably a number of challenges in implementing your work, but how have the radiologists themselves responded to this new system?
Well, you can imagine that we are adding additional work to the radiologists. They have to do something differently. And I think it's fundamentally driven by convincing our group of physicians that they're contributing to care in a different way that they did before. So that um, we are, and I think I want to make this pretty blunt, that this isn't going to be a grounds up, everybody running up and saying, we would like to do it this way, and I think it will
Mhm.
work. You need the organization and the institution support to make this a priority. And if I were to highlight one major success in my view of where we are, this program, that is our clinically significant results follow-up program that I just mentioned, is now one of our 11 strategic initiatives around patient safety across Mass General Brigham, overseen by the Office of Chief Medical Officer across our entire health system. So we've actually highlighted that this is important to the entire institution. This is not a radiology research project, that we're going to do this across the system because we see risk for our patients. And I think it's that level of importance that needs to be assigned to this work, to then engage the radiologist as part of the team that says you're now part of a bigger care process. And that takes time. That is not an immediate fix. That's a multi-year project.
Yeah, I'm thinking that in reviewing radiology reports over the years, a lot of times the language is ambiguous. And I've always felt that that was because the radiologist doesn't know the patient. There's often language to correlate with clinical findings, etc. So when you ask radiologists to put in actionable orders, that's got to be something quite different from their usual practice, right? It's got,
Yeah, that is absolutely right. And there's some really interesting things that happens downstream from that. And if I could highlight this, and this is going to be published in the next 2 or 3 weeks, actually, it'll be available. One of the things that our colleagues raised was radiologists make a lot of soft recommendations. Consider this,
Yeah.
et cetera, et cetera. When we ask radiologists to make these recommendations that are actionable, what we've actually seen now over 5 years, and we have we have the Brigham where this system has been in place, and Mass General, at the time of our study, was just a control site. We didn't do these interventions at that time. That wasn't the pilot site. Well, we saw over a 4-year period that the percent of radiology reports with recommendations fell
Wow.
by about half.
Yeah.
So we went from nationally across the United States, about 10% of radiology reports contained language that could be perceived as follow-up recommendations,
Mhm.
from very explicit, do this,
Mhm.
to very ambiguous language that could be pretty challenging. When we actually get the radiologist to think about what they're doing as an order, what happens? A lot of those soft recommendations fell aside.
Okay.
And so we're at about half the rate of follow-up recommendations in our reports, and we identify that using a validated AI algorithm
Mhm.
that we've published, and it's available to everybody. If you search it, you'll find that on PubMed, and you could use that to apply to your own cohort of reports to see what portion of your reports have these recommendations. And the national data says around 10 or 12%. And if you look at the follow-ups, somewhere between 2/3 to a
Mhm.
third of those recommendations are not executed that we have a record of. So the gap is fairly substantial.
So in the last few minutes, Ramin, talk to me a little bit about some of the successes you've had in reducing misdiagnosed or follow-up reports. Not
I
sure.
think there, yeah, I think there are two pieces that are pretty important for us. The first is we now have a very explicit measure of what portion of agreed upon
Mhm.
care plans recommendations are executed in a timely fashion, and we're tracking to about 98% right now. And the
Wow.
2% or 3% that are not performed in a timely fashion, we know exactly who they are because they're part of our record. We have captured those. One of the things we've done from a error perspective is we now have a fairly high confidence that we're tracking every recommendation to a closure, if you like.
Okay.
The number of diagnostic errors and how we formally evaluate that is actually part of this AHRQ
Yeah.
funded grant. So we've now defined what diagnostic errors would look like for radiology for these follow-ups, and we're doing a formal analysis. But I have to say, anecdotally, the number of safety events that are related to missed follow-ups have diminished quite substantially at the Brigham,
Okay.
enough so that there's enough. The question is, how much signal do we have in
Mhm.
the thousands and thousands of follow-ups that are happening? In our system, we do about 3.5 million radiology exams a year. There's going to be around 300,000 recommendations in our system. And you
Right.
can imagine tracking those is going to be a fairly challenging
Mhm.
activity over time. And most important part is reducing the noise. So
Right.
if we actually have the same success in reducing the soft recommendations, we'll have a better chance in having a detailed analysis of what happens. But that work, the formal analysis of the diagnostic error, is still underway in
Okay.
terms of saying
But
what's
in
the broad
safety events
impact.
or major events that are flagged
Oh,
throughout the
yes,
system, so
they're
those have
less.
declined based on.
Yes,
Okay.
yes.
Fantastic.
Based on the signal we're seeing
Yeah.
from our safety reporting systems.
Right. Okay. I'm gonna see what questions we have here. Um, there's a few here. So Sarah's asking, could you describe the tools, resources besides the closed loop system that you've created to communicate this process or train people about the process? That's an important question.
Excellent question. What a great question.
Yeah.
I think you'll find some of those people who are working on change management may find this interesting. We actually have created monthly feedback reports to radiologists
Mhm.
that shows them what their recommendation rates are compared to their colleagues. We show radiologists how often they're actually using the closed loop communication system. So we're actually giving people feedback on how often they're using the system. We're giving radiologists feedback on how often our referring colleagues disagree with their recommendations. And so there's a set of feedback reports that are really important part of the
Mhm.
process to make sure people are engaged. We have training documents around how to generate recommendations, and training documents for our referring colleagues and how to interact with the BPA if they wished our care coordination team, for example, to transcribe orders for them and contact the patients to bring them in. So there is a set of resources around training to use the system, and there is a set of tools for improving the adoption of the process by the radiologist. One thing that I should mention, I think, given the fact that everybody's interested in safety on a call like this, is the question is, how do we make this easier? And is there a role for generative AI, and is there a role for artificial intelligence? And this is hot off the press. It's on PubMed yesterday, I think, that when we actually took radiology reports impression and used ChatGPT in this example, we were able to extract details of the follow-up recommendation to actually create the object that you need, the actionable
Wow.
recommendation in
Okay.
Epic. So really promising result, and that will reduce the workflow and the
Yeah.
integration requirements because you use the text. What it fails to do, and it's obvious,
Mhm.
if radiologists used ambiguous language and didn't put that information in the text of the report, there's nothing to extract. So you still have the work to do, but there are opportunities, we think, with these large language models to reduce the footprint of the tools you need from an IT perspective and in the
Mhm.
integration you need to make it more flexible and scalable.
Right. That's fantastic. There's probably some additional questions here. I just had one quick question. Are your residents trained in this whole new culture and new system? Because they'll go out into the world and hopefully this.
Fantastic,
Yeah.
fantastic question. So the resident at the Brigham have been, and across our entire health system, there are 12 hospitals, and the other trainees, they go live. The radiology trainees go live on Tuesday with using the tool in other hospitals. The
Right.
the Brigham residents have been, and the trainees on the in the inpatient and ED, they have been, and that's a bit of a different workflow because if there's a pancreas lesion follow-up MRI, you're not going to do it as an inpatient in 6 months. So we have to make sure those inpatient transitions of care and ED transitions of care are then handled by the longitudinal provider. And there's a whole range of workflows around that we won't have time in this short period of time to deal
Sure.
with.
Well, that's great. Great work. So we are almost out of time, but let me open it up to the larger group and see if there are any questions. Esther is saying, really fantastic innovation to address a major opportunity for safety. Thank you, Esther. Any questions? Oh, Eva Johnson, who's a colleague of mine, she is asking, what percentage of radiology studies do you find?
Sorry, he already answered this. I typed up before he was
Okay.
answering. You were saying like 5%.
It's
How
about
have
10%, actually,
Okay.
nationally about 10%, 10 to 12%.
5% at your institution once you got the
Yeah.
more indiscriminate language down? Yeah. Okay.
And no, after we got it to 5% post interventions. But so this will be on PubMed in the next 4 weeks. You'll be able to see it and with the detail that's there. So one of our goals is to make sure everything we do is published so people can make it better and critique it. And we hope others do and make sure that the systems we're trying to work on gets better
Have
because
you
I think
found
there's just a lot of opportunity.
have you found that people have been more actionable? Like once you put these alerts in there, you said about two-thirds were not addressed. Have you found that
Um,
percentage has gone down now that
Oh, yeah, quite substantially. As I said, we track the recommendations. So our actionable recommendations closure rate, on time closure rate, is about 98% right now, 97%, which is remarkable, actually. And I think the most important part, I would say, and people worry about how much systems, how much, you put a safety net. We have 8 or 9 FTEs that are just safety net FTEs. But because these exams are actually getting performed and there's a safety benefit that comes from there, that the individual transactions that occur are enough to fund those safety net programs. So programs like this, over time, they will pay for themselves. You don't have to go and look for donations, so to speak, from other places. So there is a way to actually fund this important safety program, not just from reducing risk, but the transactions that happen on a daily fashion.
Great. Well, Ramin, fascinating discussion. I wish we had another half hour or so. We don't. Thank you so much for joining us. And it sounds like you're doing wonderful work. We look forward to hearing more and reviewing some of those publications you referred to.
Thank you so much for the invitation. I really, really appreciate it. And thanks for those who called in.
And for those of you who are on, this will be on ViewMedi and also on YouTube to view. And hopefully we'll get lots of views this time and lots of excitement generated around this new project. Thank you, Ramin. Have a wonderful day.
Thank you. Take care. Bye-bye.
Bye-bye.
Thank you.